So my real thought was to try to teach some pharmacology basics. So that'll be the Pharmacology 101. Also, one of the things that has been definitely difficult for me, just in my time, has been collaborating, period. So hopefully some tips on being able to do that in effective ways. And then the other question that often comes up, I think especially because we live in Austin, is I can send the people that I see to see a psychiatrist, but are there some things alternative medicine wise that I could suggest that might be able to be helpful for the people that I see? So that's what we'll maybe get through. So this is me. I talk about my training. I went to UT for undergrad, then I went to Baylor College of Medicine in Houston for medical school, and then I went to the University of Colorado for residency and fellowship, and I was a chief of the outpatient clinic my last year, and then I came here. I'm here, you guys know that part. I also do part-time private practice. 1 day a week I'm at Bluebonnet Trails, which is an MHMR. Then I also help with med students at Texas A&M, and I have a fellow at Dell, and then I'm also wife and mom, and you can see my adorable family. That's my husband and my son and my daughter. Okay, so psychiatrists, I think you guys probably know this already, but I think that there's a huge variety in us. I think some of us are very therapy oriented, like myself. Some are very meds management. You're here 10 minutes in, out the door, tell me what I need to know. Almost every psychiatrist I've ever met is crunched for time. I think that has to do with billing and coding and those that choose to take insurance. And when I have tried, I would say I generally get a response 50% of the time. So don't take it personally. Definitely when I have tried to talk to somebody's inpatient psychiatrist, or even if we're coordinating care for some other reason, I will say it has been pretty variable. So these are just some kind of hints that I have got over time. If you have a release of information, don't feel like you have to get the coordination back before you release the information. You are covered, right? So if you got a release of information to talk to their psychiatrist, you can feel free to say, hey, this is Dr. Elizabeth Calvin. I was just, I was calling regarding so-and-so. I just wanted to let you know I have seen some things that I'm concerned about might be something like mania. They told me that they're not sleeping. They told me blah, 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 whatever. Their mother hates them. Here's my number. Feel free to call me back if you want me to know things. Bye, right? And that hopefully will give you the ability of not necessarily feeling like, okay, where's your fax number? Let me fax you the ROI. Really, if you have the release, you're fine. And also, psychiatrists can accept information. We all, right, can accept information from anybody. You can't give information, but the thing that dictates whether or not you can give information is whether or not you have the release. So, I think if you call, leave a message, and then give your contact information and when they can contact you. Hey, here's my number. I'm generally free on these days. You can also send me an email at this. Sometimes that really helps and speeds up your care coordination. And a lot of psychiatrists really want to know this stuff regarding meds. So if definitely I would want to know if somebody was being seen and they were more agitated, they were more irritable, anything that you guys thought was related to something that I need to handle, I would want to know. I've also had therapists tell me when they feel like, for example, somebody needs a PRN, like they're really struggling at school around tests, or they have this thing coming up this weekend and they're really worried about it. I was thinking that maybe you could offer something to help them, right? So that's the kind of stuff that I for sure would want to know about. This is like a huge pet peeve just of everybody that I know. So I do care if you think that Lexapro would be good for them because their mother was on Lexapro. You can tell me that. Like, I value that information very much. But please don't call and say, I really think you should use Lexapro, because I'm going to be like, why? And that's not that compelling to me, right? If you personally like Lexapro because you tried it and you liked it or something, like, or your friend used it, like, that's not a good reason for me. So definitely I do care. I do want to know if you, for example, you may be somebody that knows a lot about medicine. There for sure are some things. So if somebody is trying to quit smoking, or they're really low in mood, then there are some antidepressants like Wellbutrin that can really help give somebody a little bit more pep. Sometimes people that are struggling with addictions do a little bit better or worse with a little bit of dopamine activity, right? So if you know that and you think like, I think they really need a medicine that's going to help pep them up, or I really think their biggest symptom is their lethargy, or like, I want to know that, because they almost always see you more frequently and tell you more than they're going to be able to tell me, particularly if I'm in that med management role. Yeah, like I said, really communicate safety, frequency, medications. The other time that I really love speaking with therapists is if they're feeling stuck about something. And I just think that's when the team is great. So if it's like, I feel like I'm really stuck, we've been trying some CBT around their anxiety and I just really can't seem to get a move on it, then again, that's for me to be like, oh, well, maybe I could try increasing their anti-anxiety medication, or, because I think that's really good information to have. So any questions or comments about that? That's like a tiny two-piece. Okay, so Pharmacology 101. You guys ready? Okay. So I am a very visual person, and one of the really important things to know is the difference between side effects and effects of medication. So for side effects, they have to do with the pharmacologic curve. This is just a general pharmacologic curve here. So essentially, you have an initial, generally relatively rapid onset, which is often an hour or so with most medications. It has to do with how is it in your blood. So what is the level of the medication in your blood? And then how does it eliminate over time? So 4.5 half-lives is how long it takes to eliminate out of your blood. So if you have a medication and 4.5 half-lives afterwards, you still have the thing, I can tell you it's not a side effect because it's out of your blood. Does that make sense? So that's what that has to do with. And think about change and timing. So if somebody says, oh, I was on Prozac for 8 months and then it suddenly caused me to be suicidal, I'm not really going to think that, do I need to do something about that?
I think you're nailing them.
Oh, okay. I'm not likely to think that that's a side effect, because if you were going to get a side effect, you were probably going to get it either when you're initially starting the medication or when you're going up on the medication. Does that make sense? So I think that's a really important thing to think about. Okay, so just wanted to go over some common side effects of classes of medications, but I put the warning because this is pretty dull. But I do think it's helpful to know, because if you know what you're looking for with certain kinds of medications, that can be really helpful. Okay, so antidepressants, which are also used for, does anyone know? Anxiety. Yeah. So those are the same kinds of medications. So GI effects are really common: stomach aches, abdominal cramping, diarrhea. Those are really common with antidepressant medications. The black box warning. So this is really important for people to know about, not because it's that concerning to me, but because they go to their pharmacy and then they see on their black box warning and they all go, ah, right? Like, that sounds really bad. So I tell people, and I'll tell you guys, this was a study that was done about 7 years ago, and in kids and adolescents that took a sugar pill, 2% of them reported suicidal thoughts. It was a retrospective study looking at any kind of antidepressant for any treatment. So they didn't separate, this is Effexor, this is this one. It's just any of them together. And so on a sugar pill, 2% of them reported suicidal ideation, and taking any kind of antidepressant for any reason, 4% of them reported suicidal ideation. So originally there was this initial concern, oh my goodness, it wasn't completion, it was just ideation. So there was this concern that maybe in 2% of kids, these medications might cause increased thinking about suicide. So people get really, really worried about that. They actually did later studies that didn't support that initial conclusion, which I tell families. And then what I tell them, which I think is really true, is the thing that's really compelling to me is that when this warning came out, the people who prescribe these meds most, so pediatricians, stopped prescribing them because everybody was really worried about it. And we actually saw suicide attempts and completions go up. So we know if you're depressed, right, your risk of suicidal ideation is high because it's a symptom of depression. And if we don't treat that, your risk of trying to do something to hurt yourself is high. So, and I tell parents, usually I say, look, I wouldn't be recommending this medication for you if I didn't think that the potential benefits outweighed the potential risks, but this is why we're having this conversation. And then I will say, I never say never. If you feel like anything is happening, like, let us know. That's what we're here for, right? I may say I don't think that's because of the medication, but if you notice something, definitely tell us. Parents will ask me, then what do you think the black box, like, what do you think happened? I will say I've never conclusively seen it happen. Some people in the field think, oh, well, maybe if you're really super depressed and then you start to get less depressed or you start to get anxious, maybe you're able to express some symptoms that you weren't able to express. Maybe. I think what happens is that, and you'll see a little bit later, sometimes antidepressants just don't work. And I think if you are a kid who's depressed and you're not having suicidal ideation, and then you come to see me and I'm like, we're gonna get you better, and I start a medicine and then it doesn't work, that might make your depression worse. And you might start having suicidal ideation when you didn't have it before. So that's my best guess, but that's not a randomized controlled trial. That's just kind of what I think. And I think that I will say, which is true, I have never conclusively seen it. I have had kids who something bad happens in their life and they start to have suicidal thoughts, or they feel really agitated and that feels bad, and that agitation, maybe makes them start, thinking those kinds of things. But I don't know that I would say, oh, that medicine caused suicidal ideation, if that makes sense. Sexual side effects, more common in adults than, I have never seen it be a problem in kids and teens. Actually, parents are like, good! But in adults, particularly older adults, it can be up to 80%. But I have also seen the opposite. So obviously people lose sex drive and libido when they're depressed, they're not interested in things that they enjoy, they're just not finding enjoyment. So I've also seen people whose sex drives increase, they're having more fulfilling relationships with their spouses because they're on antidepressants. So I definitely tell people about it, but I wouldn't want them to not take a medicine because they're afraid of those side effects when they might not even happen, if that makes sense. There are also things that we can do if it does happen, so I make sure to tell people that too. Then the last thing, obviously, is a conversion to mania. So in people that have depression, if we miss this and they really have bipolar disorder, then giving them an antidepressant can precipitate a manic state. So, and this is like classic mania, not sleeping, being risky, impulsive. So those would definitely be things that I would want to watch out for. In kids, what does that look like? It looks the same, but a kid version. So like the kids can look more ADHD suddenly out of nowhere, where they're hopping on the furniture and they think that they're a superhero. Or they, I had a kid once who started killing fish. Very impulsive kinds of things. So the same thing, if you look at, let's say you have one parent who has bipolar disorder, we know it's bipolar disorder, and they're like, I don't want my kid on an antidepressant because I have bipolar disorder and they're going to have bipolar disorder. I would say, look, statistically, your kid's risk of having bipolar disorder, if you have bipolar disorder, is 10%. Their risk of having a mood disorder, like depression, is 50%. So I would hate to see them miss out on the number one treatment for depression and anxiety because of a 10% risk, when that it's not that, assuming they meet criteria for depression, is more likely than not. So what would you do in that situation? I might start a lower dose of medication. I might go slower. I might really educate the family. Same thing. Tell your therapist about what these symptoms and have them be watching you. Really, let's be vigilant over it. And doing those things, although I have had maybe 10 or so kids that didn't meet criteria for bipolar disorder, have something that looked more like a manic state. It doesn't happen that often. The other thing to know is, like, along development, right? I'm kind of digressing, but I think it's important. So along development, you are more likely as a kid to have depression, right? And it's not until your late teens, early 20s that you often get those manic symptoms. Right. So if you are going to be somebody who has bipolar disorder, it may be literally impossible for me to know that, right? And I tell parents that too. I say, look, it could be that you have bipolar disorder. It could be that you are going to be somebody who does that, but I still think we should try this medicine, because I would hate to rule it out for your whole life. Like, this is data. Like, if we do this, I'm really sorry, but we'll stop the medicine, the symptoms should go away, and then we'll know. And even if that happened, I wouldn't necessarily diagnose a kid with bipolar if they got a manic conversion, if they've never had any of those symptoms. But I would say, look, the fact that it might happen has gone significantly higher in my mind. So, and I probably wouldn't use a medicine like that again if I had precipitated something that was like that. Okay, so, whoops. So for medication side effects for stimulants, these are kind of analogies that I like to use. Most people know coffee, right? It's a stimulant. It doesn't work the same as the stimulants that we give, but the theories are the same. So when I see somebody with like ADHD and we're going to treat a stimulant in a kid, I say, look, if I do this well, there should be a nice middle ground. So it's like if I give you one sip of coffee, what's going to happen? Nothing. Okay, if I give you too low of a stimulant dose, what's going to happen? Nothing. If I give you 2 pots of coffee, what's going to happen? You're going to be irritable. You're going to be like having palpitations. You're going to be shaking. You're going to be not sleeping. You're going to be not eating. And that is what happens if you give somebody too much of a stimulant. So I want to give you 1 cup of coffee, right? And we have these guidelines on what to use, but it's a little bit trial and error. So generally, what I often do is I start really low, and I say, look, if it does nothing, that doesn't intimidate me. I'm watching for those negative side effects, right? And if you don't get those negative side effects, great, we'll go up, because we're trying to look for that middle ground. Does that make sense? And you just kind of monitor it over time. And then if a kid starts to get irritable, starts to have trouble with sleep, that's an indication that you probably shouldn't go any higher and maybe back off because that's too much. I also like to tell parents stimulants are like glasses, so they're on when they're on, they're off when they're off. You take one in the morning, it's going to last 8 to 12 hours. I often see parents of kids with ADHD who are very frustrated about the evenings. And there are some things medicines-wise that are non-stimulants, but you cannot give a kid a stimulant, you should not, in my opinion, I think it's bad medicine, give a kid a stimulant in the afternoon, evening, because it's like me saying to you, how about I give you a cup of coffee at 9 p.m.? Like, sure, you're going to focus better and you're going to be less bouncy, but you're not going to sleep. And ideally, they should come off at like 5 o'clock so that they can eat dinner and go to bed. Right? So educating parents too. I often have kids with ADHD that I'm like, you need to do your homework right when you come home. I know that's frustrating, but you need to do it because you're going to be able to focus better, just knock it out, and then relax and enjoy your evening. The other thing that's a side effect with stimulants, so I don't know if you guys know this or not, but basically stimulants cause a direct release of dopamine in the brain. We're about to go to a slide about antipsychotics. What those do is block dopamine, okay? So if you're raising dopamine in somebody, particularly people who have a sensitivity to it or have a predisposition to psychosis, you actually can cause kids to see and hear things. So it's a little bit tricky too, because developmentally, people who are going to end up with schizophrenia often as children have symptoms of ADHD. So they have trouble focusing, they have trouble concentrating prior to getting the actual psychotic symptoms. But I would really, if I knew about a family history of that, I would not give these kinds of medications because that really, they could be sensitive to it. And there are other non-stimulant meds that we could use to treat their ADHD. Make sense? Mm-hmm. Okay, antipsychotics. So these are often used to treat people that have bipolar disorder or psychosis. There are old medications, so like Haldol, paliperidone. The way that we used to treat, this is like a little bit of a history lesson too, so the way that we used to treat people when we didn't have the guidelines that we do now is Haldol was the first, and we would give you Haldol until you started to get side effects, and then we would back off a little bit. And that was that's how much you get. And so you can even see, I'll give you guys a reference in a little bit, but if you go to Hippocrates, which is like a little reference, like the range is from like 0 to 100, okay, like milligrams. So that's huge. And most, even the times that I use it, I rarely use more than 10, okay, and get good, like it's a potent medicine. So, tardive dyskinesia is involuntary movements. Often they are sinuous or like little tiny movements, most often in the mouth. So like it'll look like this. Or you'll get a little something called snouting, which is like this. And people often try to hide it. They can be vocal as well. So I took care of someone who had been on really high doses for a long time and would have a little, like, so it can look a little bit like a tick or a twitch, but it's different because tardive means slow, so it's something that comes from a long time being on the medication. So what do we think it is? We think that we're blocking dopamine, right? So super medical. But we're blocking dopamine. There's another condition, I don't know if you guys know Parkinson's, okay, where there's not enough dopamine and you start to get these movement disorders. So we think we're blocking these receptors, and so your body's trying to maintain homeostasis, so your body will upregulate those receptors, like looking for the dopamine. And then we think that the movement disorder happens when you have basically empty receptors. So if I was to notice this in someone, which is pretty rare because we usually don't go to those meds first. Now, there's still a chance in the newer medications, but it's less so. So if there was somebody that I was concerned was having that, the first thing to do is to go down on the medication, because for a while, there is probably a critical period where if you go down on it, the movements are reversible, kind of like diabetes. If you catch it pre-diabetes, and then you can kind of, change diet, exercise, and those things, you might not get diabetes. But once you've got diabetes and you need that insulin, it's probably going to stay that way. So so that's kind of what we think about that. The new ones, though, have less of it. We were like, hey, let's get rid of the tardive dyskinesia. So we do a better job with that, but there are other side effects. So the new ones much more often have difficulty with weight gain and metabolic syndrome. So metabolic syndrome is having a large body circumference, it's having increased blood pressure, it's having increased insulin sensitivity, so things that basically predispose you to diabetes. It's not good. So kids that are on these medications should absolutely be getting blood draws every 6 months, which means some kids will refuse to, well, then I can't prescribe you that med because I'm going to do that, we're going to do it safely if we're going to do it. Certainly in the class, some are known to be worse offenders of weight gain than others. But those are the ones that we see. Now, parents read about tics and twitches and things like that, and it can happen, but if you were a neurologist, you would say, actually, it could treat tics and twitches. Haldol is actually a treatment for Tourette's, right? So, it more often helps it than hurts it. But weight gain for sure does happen. Metabolic syndrome for sure does happen, so we need to be vigilant over those things. But the same thing, if I was their psychiatrist and you were like, ooh, this kid's having a lot of weight gain, I would want you to call and tell me that because I would really want to know. And often if they're going to get weight gain, they get it quickly. So, if you've been seeing them for 2 weeks and I'm not seeing them back for another 4 weeks and they've already gained 10 pounds, like, whoa, I would want to know about that. But same thing, hopefully you're only using this when you need to. So like one of the things that's really unfortunate is there's definitely a national overprescription of these medications, in particular for kids that are foster kids. So we don't really know what's going on. We know you're aggressive. Instead of like trying to figure out what it is, probably anxiety and trauma, we just slap you with an antipsychotic, which yes, does help because maybe it sedates you, but like that's probably not really treating the underlying thing. So let's not do that. For mood stabilizers, this is a class of medication that is anti-epileptic medication that is also used for mood stabilization. So these are a little specific. But lithium in particular, you want to watch out for tremor. That absolutely can and does happen, not infrequently. Doesn't necessarily mean that you do something about it if it's not bothersome. If they're able to function fine and they just notice, sometimes I get this little tremor, you might not do anything about it. Hypothyroidism, so it can affect this is one of your metabolic hormones, so it can make it so that you are more tired, can worsen your depression. It is question how to treat this. The first question in my mind would be, do you have to be on lithium? The second question, you can supplement thyroid hormone if you have to. But I would rather not, if I have the choice, treat a med with another med, if that makes sense. Toxicity, we live in Texas. Lithium has a therapeutic range. So if somebody is going to be bumped up to the higher point of the therapeutic range, there's not a whole lot of difference between therapeutic and toxic. So the range is from 0.6 to 1.2, and toxicity generally happens at like 1.5 and higher. So that looks like throwing up, having trouble with ataxia. It's hard to miss, but particularly if you have somebody on lithium, if they're a kid and they're in baseball over the summer, I'd be like, you need to drink water. You need to make sure that take a water bottle with you and make sure that you're drinking water, because we do not want to push you into that therapeutic range. Depakote can cause weight gain, can cause tremor. The other thing in my mind for sure is it's definitely a teratogen, so I really don't like using this in adolescent females, because sometimes they're impulsive, right? And so anytime it has the ability to potentially hurt a fetus baby, I'm like, let's not do that. Lamictal or lamotrigine can cause a Stevens-Johnson's rash, so that's what that's a picture of. It sounds like, oh, it's a rash, right? It's a rash that sloughs off like a burn. So you would definitely need to be hospitalized. There's something that can come before that called erythema multiforme, which is like little petechiae, which is like little tiny red dots. Similarly, who uses this the most? Neurologists. In my conversations with them, they would say as long as it's being dosed appropriately, it's really, really rare. So the dosing for this one's like you got to do 25 milligrams for 2 weeks, and you do 50 milligrams for 2 weeks, versus like therapeutically, if you're going to use this to treat somebody with bipolar disorder, you have to get to 200. So it's going to take you a long time. Sometimes people with bipolar disorder, you can't really wait, the 2 months that it needs to get to the therapeutic level. But they would say as long as you're dosing it appropriately, you're okay. Oddly, the risk is both with going on the medicine and stopping it. So if you stop it suddenly too, you can also get this rash. So definitely important things to look for. Okay, so some resources. I don't know if you guys are app people. Hippocrates is a great resource. I have it on my phone. My whole family now has it on their phone. You can look up the med. It will tell you on there what's the med, who is it for, and it's free. What's the diagnosis? What's the range? You can look up on there the pharmacology of it. So it'll tell you on there what's the half-life. So if you're like, I don't know if this is a side effect or not, right? That should be able to tell you. It also has on there common side effects. So it lists anything that's 2% or greater. So if you have a patient who's like, I'm having blurry vision, and you're like, I don't know if this is, you could like yes or no. So that's a good resource. And then also pharmacists. So I feel like this is an underutilized resource. Pharmacists, I feel like Hippocrates is decent, but that's about all I've got, right? Even, as a psychiatrist, physicians have access to pharmacopedias. They can tell you exactly what number out of how many reported this side effect, something that's less than 2%. There was a kid that I saw who had weight gain on Intuitive, which is like unheard of. And I was like, I don't know. And I called the pharmacist, and the pharmacist is like, actually, yes, it's 0.04% of people reported weight gain. And I'm like, okay. So they're a really good resource. And the same thing if, somebody says, oh, well, I will refer my patients to pharmacists too. If they say, well, I want a med, but I want to make sure that it can't cause X random thing that I've never seen. I don't know, knee pain or something, I'd be like, well, I've never heard of it. It's definitely not less than 2%. If you're still concerned, you can go talk to your pharmacist and make sure that that's not something that's super common. But that's a really good. And then, like I said, I never say never. So if there's something that they're concerned about, there's nothing better than an N of 1 study. So if they started the medicine and they got the effect, and they stopped the medicine and the effect went away, well, that's pretty compelling, okay. So we were talking about side effects versus effects. Effects take 4 to 6 weeks versus the side effects, which should happen right away, right? In general, 4 to 6 weeks is in general. Why? So the science version is probably what happens. You increase, let's take an SSRI, for example. You block the reuptake of serotonin, which causes more serotonin to be everywhere, right? The increased access to serotonin means that your body makes changes, so it downregulates receptors. One of the theories is, okay, well, your body is starved for serotonin, so you're putting out all these receptors, like looking for serotonin. Then we increase the serotonin in your brain globally, so your body stops sequestering it, stops holding it, and after it stops doing that, we can get more targeted release actually in your brain where it needs to go. Does that make sense? But that kind of takes 4 to 6 weeks to change that receptor expression in your brain. So that's why that kind of takes longer. I do not try to explain that to patients. I say, what is it doing? I say, well, basically when you take the medicine, it's going to even out the nutrients in your brain. We're going to increase, I might say we're going to increase serotonin kind of everywhere. And that's going to help your brain heal. And I say it's like a really well-worn pathway in your brain. Like if you had a field and you've been walking down this depression pathway every day, or you've been walking down this anxious pathway every day, that's going to be really well-worn. The medicine is like throwing seeds everywhere because we're not good shots. So it's going to help you fill that in. And then what you're going to do in therapy is you're going to learn, how can I walk a different way? I don't have to go this way. How can I kind of forge a different pathway in my brain? So I like that because it kind of explains to patients why both are important too, and how one really isn't going to work that well without the other. If you do therapy, well, in moderate to severe cases. So data would say mild to moderate Therapy is equally good, which is why I might say I think you should do therapy. I don't think you should use medication. For moderate to severe cases, data would say what's going to get you better, best, fastest would be a combination. So it's easier to not walk down that same pathway if you've got little grass seedlings, so it's not as prominent, right? It's easier to kind of make those changes. So how long once people, one of the other questions people ask me, once you're on medication, does that mean I have to be on it forever? No. So there was a study that looked at adults that took 1,000 people with depression, put their brains in a scanner, averaged them, and then 1,000 people without, put them in a scanner, averaged them. And essentially what they saw was after they went into remission, it took 9 to 12 months for the depressed brain, averaged, to not look depressed anymore. So I think that's really powerful for people to know. You can actually see the change that happens in your brain when you're depressed, and then it does go away, right? So, the risk of relapse, I will tell patients, look, if you stop too soon, it's sort of like we're sort of partially healed. So I'll say, like, look, we're going to cast this bone. You have this thing. We're going to cast it. We're going to get it healed, and then we're going to take it off. But if you take it off too soon, that's not going to be good. Also, if you're going down on medication, you want to pick a not stressful time. It's like, I don't want to take off your cast right before you're going to run a marathon. Like, let's pick a time when things aren't particularly stressful. What are rates of relapse remission off of meds? So if somebody's had one major depressive episode, the likelihood that they'll have another one off of medication in their lifetime is 50%. I wouldn't recommend staying on medication, for a fifth coin toss, right? If you have had 3 distinct major depressive episodes in your lifetime, what's your risk off of medication of having another one? 90%. That's usually the point at which we're like, look, just take the medicine. Because major depression is often significantly impairing people's function, otherwise we wouldn't be diagnosing you with something. So if it's really impairing your life that much, people will also say to me, well, what makes the difference in the 50%? That's like everything else. Well, it's a combination of what happens in your life. If you go to war and lose your best friend and experience a bunch of trauma, you're much more likely to have another episode. Or if you lose a spouse or a child, or have something happen in your life. Also, we think that there are some things that we've been able to tell. Maybe you don't make as much of a certain neurotransmitter, maybe you have alterations in certain receptor transformations that may predispose you to depression and anxiety. I mean, it's a combination of genes and environment. Okay, so something else I think that it's important to talk about with meds. You guys like my little, placebos, fast acting, extra strength placebos. Better go with these. So they did a double-blind randomized controlled trial of antidepressants in adults with depression looking from 1978 to 2015. They defined response as greater than 50% reduction in symptoms, which is pretty good. And since 1991, the placebo response rate has been between 35 and 40%. So me being a psychiatrist, one of the things that annoys me is people say oh, well, that means medicines don't work. That means they don't do anything. So my first question is the placebo effect fair? Well, one, you can't really say that if you come and see any of us, right, that if somebody comes to see you, but you don't teach them a technique, you don't do anything, right, is that really the placebo effect? Probably not. Probably they know that you care about them. They know that you're trying to help, right? The other thing that comes to my mind, it makes me feel better, is they looked at a study of clinicians who did treatment of care as usual, so prescribing according as usual, not prescribing according as usual, and then they also looked at whether or not they felt like the provider cared about them. Not surprisingly, who did best was prescribing as you're supposed to, and they thought you cared about them. But second best was they thought about that you cared about them and you didn't prescribe as usual. So, right, we know that this is hugely important, that when they come to see us, there are healing symbols and rituals, that giving somebody an evaluation is going to help them to get better, right? That discussing what they have, what they can expect, that you have seen people like them, that you have seen get better, right? I don't really think that that's placebo. I guess maybe it is if you're defining that as just a medicine, but there are other things that also happen. Diagnostic tests, interestingly, are an independent factor of recovery. So if you had a heart attack and I give you a CT heart scan, you're more likely to get better than if I don't give you the CT heart scan. So that's kind of interesting. We also know that people's expectations hugely impact how they do. So many people will act, if they think they're drinking something alcoholic, people will often act as if they would if they had had alcohol, similar with caffeine, and they can have physiologic responses that go with those things, even though they haven't really had those things. One of the really interesting things is they gave people atenolol, which lowers your blood pressure. People who had high blood pressure, then they came in, they had high blood pressure, they said, we're giving you atenolol. It wasn't atenolol. Their blood pressure still went down, right? So I guess that's placebo effect, but it's pretty powerful however you think of it. Similarly, you can have a conditioned response if you have asthma and you're used to getting a nebulizing treatment, and that opens your airways physiologically. If I show you a nebulizer, often your airways will start to relax in preparation for getting that. So then there is this question, which I think is fair. Why are response rates so low for medications? So response rates are generally about 50%. So that's, people say, oh, response rate for medication is 50%, placebo rate is 30 to 40%, so clearly taking a medicine is only going to help you 10%. I don't think that's quite accurate. So I think what fits with one of the mentors that I worked with, and I agree in my clinical experience, in any other area of medicine, this is how we're looking at this. So on the, I don't know what that is for you, the one that's kind of graphically up and more boxy, that is actually looking at tumors using 2 chemotherapy regimens. And what you can see is they divide them into responders and non-responders. Some people respond and some people don't respond. So some people's tumors respond and some people's tumors don't respond. I would say I have a very similar experience in treating people with antidepressants. Some people it does nothing for, which is why if you look at like STAR-D, for example, they will say standard of care is you got somebody with depression, you start them on a medicine, you see them back in 2 weeks. If they've seen any difference at all, good, you keep going. If they've seen no difference, you switch them. And that is because people generally are responders and non-responders. But in my very fancy diagram that I drew, you can see if you have a group of people that respond and a group of people that don't respond, and then you average it, you're going to get about 50% response rate, right? So I think that's my best guess, that it works for some people and it doesn't, which is why our treatment guidelines, if you're a non-responder, then I switch you to a same class. If it doesn't respond, then I go outside the class, blah, blah, blah. Any questions or thoughts about that?
I guess, one of the things for me, when a client thinks about taking medication, they kind of have this conceptualization of, I'm going to go and then take the medicine, and now I'm going to do the skills in therapy, and it's going to be more helpful. Kind of like we were talking, maybe we decide the depression is significant enough. But I think one of the really good things you're sharing there is, obviously working with you is a process just like working with us, right? Mm-hmm. And so they have to build some rapport for the medicine even to be more effective and things like that. But what do you think is a good thing for us to do on the therapist end for when our client is waiting for that intake for the medicine to kind of give them a realistic expectation without maybe making them feel like, oh, the therapist doesn't think it's going to be effective, right? Because I think sometimes when we talk to our clients and we say, well, you're going to probably try this medicine, and then you may try another one, and then eventually we'll find something, they interpret that as like, we don't have a ton of faith in the system.
That it's going to happen.
Yeah.
So what I tell patients is, as long as we are taking small, positive, consistent steps, we're going to look back in 6 months and be amazed at how far you've come. Mm-hmm. And I'm like, we're going to do that in every way that we know, right? So like maybe they start to work with you guys. They're starting to learn some, maybe it's like crisis management, coping skill, they're getting some positive movement. Now they may not be in a place where their life is happy and productive like they want it to be, like they're not their ideal version of themselves, but that's positive, right? Then maybe they come see me and maybe what they feel like is, okay, I've got somebody else on my team who's going to help me look at things from a different way. Maybe I say, okay, we're going to try medicine, and I try to set them up. I would much rather not do something bad to you and have it take a little bit longer than do something too fast and it screws things up for you, right? So saying and explaining that, I think kind of lets them know what to expect. So, I will say meds often for people, the change that they notice is retrospective. So like if you have an irritable kid or if you have a sad kid, I'll say what working is looking back and being like, that's weird, so-and-so said that to me, and that would have just wrecked my whole day. I'm still sad about it. I still didn't like it. I still thought about it for a couple hours, but it didn't really ruin my whole day. You know, I think you're right. There is this like, oh, both ways. This medicine is going to change me. It's going to change who I am. That's not the goal, right? I mean, it's to kind of help stuff roll off your back a little easier. And I would say this is just another way. We're already doing this. We're already teaching you these skills. We're already teaching you how to handle it. Hopefully, the medication is going to be something that just helps you handle it in a different way. Because, you know, but just like I'm going to give you a skill and you might have to practice it to get better at it, right? I mean, you're going to go see somebody for medication and they're going to start some medicine, but it may not be perfect when you start. You may need a different medicine. They may need to go up on the medicine. So we're just going to work together with them like you're working together with me, and then it's going to get better over time. And just try to keep them focused on the long game. And then I tell kids all the time, I'm like, look, I understand that you may not have a lot of faith that this is going to get better. And I was like, you can borrow mine for a while. That's okay. I've seen a lot of kids. I mean, you know.
That's a phrase I use a lot too. Borrow mine. I have hope for you.
Yeah, exactly. Okay. So, and we have like 10 minutes left, so I'm definitely not going to get through with this, but I'll go as fast as I can. So the kind of disclaimer, I don't really know about this, so I would just recommend talking to your licensing board or maybe somebody who does this, knows this better than me. When I was looking into it, there was some question about, like, I know that if I suggest an alternative medication, that is that is practicing medicine. So I don't know if a therapist were to specifically recommend something, if that would be practicing medicine according to their licensing board. Now, obviously, there are ways that you could say it. Some people take melatonin for sleep. Like, you know what I'm saying? Like, without saying, I think you should do this. But I did look up the Texas Occupations Code because I was like, what is it, right? So they said practicing medicine means a diagnosis, treatment, or offer to treat a mental or physical disease by any system or method. So I don't know. I would imagine that whoever licenses you would know. I don't know does anybody know the answer to this? Like, and sometimes people do things that I consider like, wow, that's pretty out there. And then I will often write when I'm documenting, like, okay, to continue this, and this as per family preference, right? Does that make sense? Like, if it's something that they're doing doesn't seem to be hurting them, but I'm not sure that I would recommend it, I might put it that way, just so that it's clear that I'm not saying, oh, I had a therapist suggest to somebody that they start taking lithium salts, which is not this. They gave them a blood test. Their lithium level was low because lithium is designed to monitor oral lithium that I give you. So if I'm not giving you any oral lithium, obviously it would be low. And they were like, your lithium is low. You need to take lithium salts. And then they were like, well, I just am going to keep taking these. And I was like, okay, you know, I mean, I don't feel like I know that much about that. So it was okay, but I wasn't suggesting that they continue it. Oh, that's a problem. Oh, okay. So does anybody know pop quiz? Does anybody know what this is?
It's like salt.
I kind of gave you a hint.
Lithium salt.
It's lithium salt. So we found lithium. Actually, lithium was originally used as a salt substitute. And then we noticed that people were using it were pretty mellow. So I guess talking about alternative meds, I do think there are some things. I think they are great, but I do think that sometimes they can be overstated or overused or used when really a prescription medication is needed. And I think there are some general things which I'll talk about, like, oh, they're safer, they're really not tested. So, you know, I mean, like, for example, one of the ones that I hope that I have time to get to is cannabidiol. I don't know if you guys know, do you guys have people who are using cannabidiol? So cannabidiol is part of marijuana. So marijuana, there are two parts of it, THC and cannabidiol. And basically cannabidiol is now legal in Texas, and there are drops and all kinds of stuff. And the reported benefits are everything. And I have had a bunch of people who are wanting to give it to their kids. And the one case, and that's not to say cannabidiol absolutely has therapeutic properties. I'm not saying that it doesn't. But the case that it's actually been most studied is in treatment refractory seizures. And there was I'll maybe get to it, but there was a meta-analysis looking at the benefits of using cannabidiol in treatment refractory seizures. And the conclusion of this like Cochrane review, huge meta-analysis was, we don't know that this is safe. So, I mean, if I had a kid with treatment refractory seizures, I might use cannabidiol. But if my kid was anxious or having trouble sleeping and there were like 30 other things that I could use the things that you know what they're going to do, right? As opposed to the thing that we don't know what it's going to do, right? I mean, when tobacco came out, everybody was doing it because they thought it was great. Okay, so I have 5 minutes. I'm probably going to skip this. So essentially, this is what I'm trying to do here is I went to the Chopra Center that's talking about ashwagandha. Ashwagandha is a potentially helpful medication or not really medication, herbal supplement for treating anxiety. And it's like, so this one is saying like, it's Indian ginseng, doesn't it look beautiful? It's so wonderful. And it says it treats stress, fatigue, lack of energy, difficulty concentrating, and it can help support an energetic and rejuvenating sense of well-being, and it all sounds wonderful. Has benefiting and healing effects, stabilizes blood sugar, lowers cholesterol, enhances sexual potency. Who doesn't want this, right?
Yeah.
And it's an adaptogenic herb. I was like, what is that? They are substances that modulate your response to stress, blah, blah, blah. Great, add it to your diet. And then I'm like, who wrote this? And she's a yoga instructor, which doesn't say anything. It doesn't say anything. She might be really well studied. I'm sure she could review literature, but I would be hesitant myself to take something that does potentially have psychogenic effects on my brain, on my body, as per somebody whose main thing is that they have studied yoga and meditation, which is wonderful and helpful. But I'm not sure that I would want to. So let's go to the literature. So this is my point, is where do you go, okay? So the literature, here is something from the Indian Journal of Psychological Medicine, prospective, randomized, double-blind, placebo-controlled study of safety and efficacy of high-concentration, full-contact ashwagandha in reducing stress and anxiety in adults. So I don't know how much you guys know, but those are like gold keywords. Prospective, randomized, controlled, double placebo, right? Sounds amazing. Basically, they had 64 people with chronic stress, and they were randomized to placebo or control group, and they each took 300 milligrams of high concentrated ashwagandha. And what happened? They exhibited a significant reduction in stress assessment on day 60, P000.6, which significant is usually less than 0.01, so super significant, right? And so you're like, wow, okay, that's pretty cool. That's a literature reviewed source. So, but then though, you have to also, trying to figure this out, you have to look at the placebo, the participants. Does that apply to who it is that we're helping, right? So for example, these people, 18 to 54 years, free of psychiatric conditions other than stress, so no depression, no anxiety, a stress score of less than 15, and at least 14, so they're like not super duper stressed, they're like middle stressed. They can write English. They were excluded if they had any physical condition, any physical chronic condition, any hormonal imbalance, any psychiatric illness, any hormonal birth control, any medication on a regular basis, taking any herbal preparations, including ashwagandha, ginseng, ginkgo biloba, pregnant or substance dependence, or any abnormal laboratory or ECG findings. So I'm like, how many, does this apply to any of my patients? Obviously no, right? So then it's like, okay, so what are you supposed to do, right? You can't just look online. You can't even necessarily go to a literature-reviewed source. There are some, so my suggestion to you guys when you're looking for information is look at a literature-reviewed source. So this is done by the Cleveland Clinic Wellness Supplement Review. I put on there was another good one that I find that kind of talks about pros and cons and describes it. So what is it for? Anxiety, they gave it a rating scale, -1. Theirs goes from, I think, 3 to -3, so possibly ineffective. Depression, possibly ineffective. Talks about pros, talks about cons. So for the same thing, at least people can know what to look for, right? Can it irritate the gut lining, cause nausea, vomiting, diarrhea? But even if I decided I wanted to use it, I would want to know what to be looking out for, right? So look for a literature reviewed source. It also will often give the dosage recommendations, and then it gives a conclusion. And then the really important thing is look at the references. So I didn't even put them all on there, but it should have kind of where they're getting that information from. So we're not going to have time, but I did talk about some alternative treatments that I think are super duper helpful. So for depression, Beyond Blue has a really nice guide. lifestyle changes. Melatonin for sleep can be really helpful. Benadryl for sleep can be helpful. A multivitamin can be helpful, particularly in people who don't have the best diet. So if you have a kid who's like, I only eat chicken nuggets and french fries, like a multivitamin might be helpful for them. L-methylfolate has been shown to be effective independently, and also particularly for people who have poor responses to SSRIs. In some percentage of people, it can increase their response. It can basically make 50% of people who didn't respond, which is impressive. TMS, ECT, alpha stim, these are kind of like little changing the orientation of your brain. It's like electroconvulsive therapy light, kind of bright light therapy. There's a lot of good data for SAMe, St. John's wort.
Actually, I had a TMS rep talk to us maybe 2 months ago.
Yeah. And that there is good data for that. Anxiety, mindfulness meditation, aromatherapy, TMS, alpha stim, L-theanine. So for kava, for example, one of the things that probably has to do with like how it's mined, but you know, in like 1 in 10,000 people it causes hepatic failure. So like I would be really hesitant to take that. You know, it's not regulated. So the FDA, and I may have, I don't know if the FDA basically classifies alternative treatments as foods. So they have to prove that they're unsafe. They don't have to prove they're effective or safe. And then they actually won a lobby in 1997 that said that they can use claims that are based on low, limited, or poor quality data. So they can make claims without having to prove them. So, and then ADHD, avoiding red 40 significantly improves ADHD in 10% of kids. That's pretty impressive. Aromatherapy, fish oil, bipolar disorder, social rhythms, focus on sleep, fish oil. And then I kind of said this too, like I kind of went there already, but you know, vaping is not okay. Thankfully, since kids have been dying, people have been suggesting this less, but I've seen a fair number of kids whose therapists told them to start vaping.
Wow.
And I'm like, no. So cannabis, cannabidiol, I have had people who they suggested they start using marijuana. Like, please no. So, you know, and I would say, so for example, I have had some patients who have chronic pain or things like that, adults who are like, you know what, I feel like nothing's working. I want to try cannabidiol oil. And I'm like, okay, let's try it. Probably 5 people. And what we have seen as those 5 people have tried it is that it does work, but they get tolerance to it, meaning it stops working as well over time. And then if they stop it, they get rebound chronic pain, rebound anxiety. So, I mean, if you're going to use it, just be mindful of what you're doing and don't get to a place where you're using 80 capsules a day. So we won't do the case presentation. Where do I end? You know, prescribed medication is not necessarily more risky than alternatives. The risks are just more known. I've had some kids say like, please, there's nothing bad about pot. And I'm like, there is no psychoactive substance ever that doesn't have risks. I just can, you know, like everything I give you has risks. I don't believe that it doesn't. I mean, there's data to say it. It increases your risk of soft psychotic symptoms 200%. It increases your risk of actual psychosis like 6 times. So, you know, I don't believe that it does nothing. But also, there's no substance ever that does nothing. The other thing that I think is just hard is that kind of as these one agents are studied, often they're combined. So it's like a poly whatever. So that's even harder to know because if you're going to study it, one agent is easier to study. But I also tell people, like, look, there's nothing better than an N of 1 study. If you try it for a month and it makes a difference, keep doing it. Like, if you try it for a month and it makes no difference, probably don't spend your money on it. But I don't think there's anything wrong, especially if you have people who are suffering from chronic stress, or who are very well and opposed to taking medication. Like, I don't think there's anything wrong with trying it. But if you are suicidal, your life is at risk, I'm like, please, like, let's do the thing that we know works, and it's not necessarily less safe than this other stuff, right? Does that make sense? But you just go with So examine.com was the other resource that when I was looking at, it looked like it was peer reviewed. The Cleveland Clinic stopped selling supplements, so sadly they took down their resource, which I loved. But I made one about depression and anxiety, kind of pros and cons. So I'm happy to give that if you guys want. The other really nice thing is the Natural Standard, but you have to pay to subscribe it. You could actually get a book. I think the last one was in 2005. So I have the book, but it's not the most updated. And those are my references. Any questions about anything? Sorry we didn't get time to do the case, but
It was my fault.
it's not your fault.
Technology.
Great job.
Yeah, that
Thank
was
you.
awesome.
Yeah, that was good.
Probably too fast to retain, but you know, hey, there you go.
Can they have those slides?
Yeah.
Sure,
Yeah.
I love the slides, yeah.
no problem.
If you just leave it up, we can just take it.
Okay, sounds good.
I'll make them into a PDF and then send them to those that attended.
Cool.
Yeah, I was thinking it's already a Google slide on your thing. So more when I worked in Dallas, but and that was because we had more substance abuse related people. They were looking for these, silver bullet treatment things, and so there was like obsession with CBD stuff, obsession with ketamine treatment stuff, and I mean, just for me as a person, I see all of those therapeutically, which is you're hoping that you can do a ketamine treatment rather than PHP and then IOP and a long-term thing, but I don't know. Could you talk about that?
Yeah, I mean, I'm so practical. If it sounds too good to be true, it probably is.
Yeah.
Right? I mean, the data in ketamine is like, yeah, you feel great for up to 6 hours after you take ketamine. I'm like, aren't you still high? Like, of course you feel great, And I mean, I don't think that there's anything wrong with, if you have tried everything else and there is literally nothing else, would I suggest, like, I've tried every medicine, you've tried every therapy, would I say, you know what, we're at that point, I think you should do ketamine? Sure. But just like if you were somebody who's using opiates and we're like, where you are to get you functioning, we're going to do methadone, right? Like, yeah, you know what, that does have a place, but the place is not for everybody, I think that it's not a question of does it work. With pot and cannabidiol, is it not a question that it works? No, I believe that it does. You feel good when you're high. You do feel more relaxed. It's really like, what does it do to you, right? Like, I mean, tobacco industry, we didn't know until 30 years later that it causes cancer and death in 1 out of 10 people. Like, that's huge, right? But we didn't know that until 30 years later. So ketamine and cannabidiol, we really don't know. So that's what bothers me when, like, I mean, I've had 6-year-olds that they're like, so we just started giving her, we found a cannabidiol gummy and we're just using that. It's really great for anxiety. And I'm like, please just like let me, if your kid is having anxiety, I will treat the anxiety. Like, I can do that in a safe way. Like, we can use some Buspar. It's safe. It's not addictive. It's not, the side effects are that it can make you sleepy. I'm pretty sure your cannabidiol could do that too, right? Like, so I think everybody wants the easy way out, but that's not really the best thing for you ever, right? I mean, like, I want to go to Vegas and win $1 million. Is that likely to happen? Like,
That's a pretty good comparison.
Yeah.
I mean, and I understand the desire. I want to be able to play guitar tomorrow, but is that going to happen? So the other thing that kind of in that note that just to mention is, there's a lot of emphasis on the genetic testing now. So I don't know if you guys are seeing this, but like everybody wants the genetic test. It's not that it's bad information to have. It does tell you how you metabolize medicines. So if you're going to be a fast metabolizer, you might need more medicine. If you're a slow metabolizer, you might need less medicine. And then it can tell you that L-methylfolate thing, if L-methylfolate will be helpful for you or not. But then the other stuff that it claims, we really don't know. So it can tell you if you have an alteration of a serotonin transporter. Yes, it can do that. However, we do not know if that means that you respond to medicines differently. You have 6 serotonin transporters, so the fact that one of them is different, I've seen people like completely exclude SSRIs, which is the #1 treatment for depression, because 1 out of 6 receptors has a slightly altered conformation, which doesn't say about how the medicine is going to bind with it. Like, maybe it's the inside that's messed up. Like, we don't know. There's never been an in vivo trial, so I feel like they're overreaching. I've seen people with like anxiety be put on lithium because the gene test said that they would respond well to lithium. I'm I'm like, well, do they have seizures or bipolar disorder? Because that's what's been studied. And lithium and anxiety, like, I don't know, and why would we make you miss out on, there's no difference statistically in treatment according to usual, which is like using our guidelines, versus treatment with a gene test. So it's like, I tell people, like, look, the things about metabolism, I'll probably figure that out. If you have a response to something, one, I'm not going to start you on a crazy high dose anyway. So if you end up needing more, then I might suggest, hey, why don't you take this vitamin? If you have this deficiency, it'll make a big difference. If it doesn't, it won't. The cheapest that I've seen the gene test is $200. Without insurance, a pill bottle is $30. So like, just test it and see if it works, and if it does, great, keep doing it. Kind of like we're talking about with the herbal supplements, So it's the same thing. I think it's this desire. People really want, can't you stick my head in a scanner and tell me what's going to work for me? Maybe one day, but not today. And I've seen people waste thousands of dollars on, and I say waste, they were ineffective. But on like, let me play these clicks in your ears and that's going to completely cure your ADHD forever. Now I'm not sure that I would, right? If that was effective, would I see that person? No, I wouldn't. But I've seen a fair number of people that have tried those things and they haven't been, or like someone came in and they're like, I have ring of fire ADHD. And I'm like, what's ring of fire ADHD? And they're like, they put my head in a scanner and they saw this activity in a ring of fire. And I'm like, well, what does that mean? Do I like treat that differently? Do I well, your treatment's gonna be the same, right? I'm gonna want you to learn some organization skills. I'm gonna make sure you have a 504. I'm gonna think about, have you have you tried fish oil? Have you done Red 40? Do you need a medicine that's gonna support ADHD that I can prescribe to you, right? Like, the questions are still the same. So, I would love it. And there is, for people that are interested, there is something that's looking at, it's called the RDoC, which is looking at physiologic measurable criterion. I actually did a talk on it. I could give you guys a talk if you wanted. But on like looking at measurable criteria in psychiatric illness. So like, how well are you able to adapt to clicks in your ears, or how well does it have visual changes? Can we monitor your cortisol? And then those correlates, looking at can we tie those things to psychiatric illness, and probably risk factors for psychiatric illness, as opposed to like high blood pressure is a risk factor for heart attack and stroke, and right, like, it's probably really more similar to that. So they are trying to do that, but I don't think that's going to tell us anything. We're headed in that direction. I feel like we're a relatively young field. We've like, I don't know. If we look at like the first therapists, like late 1800s, I don't know. Like, it's still, versus like cardiology. Oh, I don't know. Like 15, 17, like, we're a relatively young field. So, so I think we have a ways to go. But I think I hear in that people's real desire of like, please just fix me. Please just, and I wish, like, I'm like, where's my magic wand? I left it at home. Like,
And I think that kind of like going back to the first question, right? That's the same stance that so many of our clients have, where they hope going to meet with you will give them the same results that a ketamine treatment center says they will receive. Like, you're going to come, you're going to meet with this person, you're going to leave. Maybe they even give you some samples, right? And then you leave and you feel amazing. And so, yeah, therapeutically communicating, that's not how we want it to go anyway.
Yeah, and I tell people I will not do anything that I think is going to be bad for you long term. I was like, I say I'm a long game person. I'm not a short game person. And I'm like, sure, I could give you some things that are going to make you feel better right away. And I'm like, you could take some illegal drugs. They're going to make you feel better right away. Does that mean that that's good for you? Does that mean that that's what I want for your life? So that happens a lot with like benzodiazepines. I'm anxious, I want Xanax. And I say like, look, I have seen people, I feel like it's completely misprescribing. And if I say, oh, just take Xanax 3 times a day and I don't give you anything else, you're going to feel great, except that that's going to stop working over 6 weeks, and then you're going to get more anxious. And when you withdraw, it's like withdrawing from alcohol. You can get psychotic, you can get delirium tremens. Like that's not good for you. So I'd much rather do something that's going to take your anxiety from a 9 to a 7, like I understand that that's not a 3 and that that's what we're aiming for, but you've probably been in a 9 for a really long time, and maybe you are just okay with it being at a 7,
Yeah.
you know, and maybe you're learning some coping skills, and then over time I'm going to get it to a 5, and then that's the goal. We want to get it to a 4 to a 3, but that may take 6 months, you know, and I think that's much better. To me, it's like treating somebody with an opiate. If you have pain, my mom had horrible rheumatoid arthritis. My grandmother, like her hands, like they told her she was going to be an invalid. She's like a really tough lady, and she hated opiates and she was smart enough to figure it out. She was like, I can't handle coming back to the pain. I can't handle like knowing that it can be gone and then having to come back to it. So she refused them, which was really smart. They wanted to give her morphine because that's what they had, you know, and it completely, you know, made her non-functional. If I give you something that's good, that's actually like in depression in kids, right? One of the biggest differences, they can have moments of not depression. Usually adults are like, oh, all the time. Like kids, I've had parents say like, well, they're not depressed. I see them happy and playing with their friends. That's one of the big differences. Kids can have moments of not depression, right? And people assume, oh, well, that's better. Except I don't think that it is necessarily, because then you have this moment of like, oh, I feel better. And then like, oh, crap. Like, I thought things were better and they're not.
Yeah.
So I think it's the same thing. So I think those like things that are going to relieve you rapidly, but they're not long lasting, I think it's doing people a disservice. And I just tell them that. People get it usually when I'm like, look, I could start you on this medicine. Yeah, it'll help for 4 weeks, and then it's going to be worse than it was, and then I'm going to predispose you to addiction, and then I'm going to predispose you to Alzheimer's. Like, is that really what you want me to do? Like, you know, like, most people are like, well, what other choices are there? Like, because there are other choices. I just think it's that desire, which we all have. Like, I mean, I would love to, if you could guarantee me, if you're like, you go invest $1,000 in the slots and you will win $1 million, I'd be like, I'm sorry guys, I gotta go. Like, you know, I mean, that's a desire we all have, but I just don't think it's fantasy.
Yeah.
Okay.
That was really awesome. Thank you.
Yeah, thank you guys for having me.
Yes.
Yeah.
Second round.
Not necessary. Okay.
Hey, I'll keep you in the loop on the 99214.
Oh yeah, that's so weird. I don't know. I mean, I don't even know, like, who could I ask about that? Like, that's what my friends use that are in private practice.
Yeah.
Like,
I'm wanting the medical billing company to chime in, but what he has already chimed in doesn't make sense.
no, 908 does not make sense. It's an add-on. That's
Right.